Okay, thank you so much. Okay, well, again, I apologize everyone for technical difficulties. First, it was me with my connection to the internet, and then it was David's. So it just seems like one of those mornings. But it's a pleasure to be here with you all, and I wanted to take this opportunity this morning and to thank you for making time in your day. And we'll talk a little bit about contact lens fitting and the use of some of the great Oculus products. As Kai mentioned, I am at Indiana University. I have the opportunity to teach about 75 students a year in contact lens practice. And in our clinic, we have both the Oculus Keratograph 5M as well as the Pentacam. And so we'll talk a little bit about those two uh, tools, if you will, today, and how we utilize them and how you can utilize them in your practice. Modern contact lens practice really, it's evolving, and the technology and the software that we're increasingly getting the opportunity to work with requires having high level diagnostic equipment in order to properly utilize these this new technology for lens creation and design. And so again, we'll talk today about the Keratograph 5M, which is a corneal topographer, as well as the Pentacam corneal tomographer, and how you can use them in your practice to provide higher level contact lens care, differentiate yourselves. So in our practice, because again, we have the luxury of having both items, the keratograph serves as our main tool for corneal imaging on the regular cornea patients. So what do I mean by that? When we have a patient who wants to wear soft contact lenses, disposable lenses, basic toric RGPs, orthokeratology, these are all patients who, while they need correction, they have normal corneal shape. And so for those individuals, we use our keratograph pretty heavily. And the keratograph works great for baseline corneal measurements and screening before we begin a fitting. And the poll question I was going to ask you today was, what percentage of your patients do you do corneal imaging on prior to beginning a lens fitting? And we do them on everybody, partly because we want to obtain information about eye shape and how it will impact how we do our fitting, but also because we want to have baseline information to check for pathology or subtle problems before we begin the process. So we use it for our baseline measurements. We use it for contact lens fitting and follow-up, and that can be orthokeratology, like I'll talk a bit about today, but it can also be for every patient. We certainly use the raw data that we get from our topographer, our keratometry readings, our corneal diameter readings, et cetera, to influence even our basic soft lens fits. The Keratograph also has the wonderful option of doing a lot of anterior segment imaging with the cameras that are built in, both white light as well as cobalt blue for fluorescein. We also have the option of doing infrared imaging. So there's a lot of great application for following those contact lens patients, whether it's, again, just baseline fit information or follow-up of complications that may arise and being able to document and follow those. And then, of course, the Keratograph has the great option also of being a dry eye tool. And that is something, again, which for our contact lens patients, dry eye is certainly one thing that we need to be focused on. So the Keratograph brings all of these to you. I'm going to take just a second and compare corneal topographers. For many years, I worked with a small head topographer like the one you see on the left, and about 10 years ago switched over to using my keratograph. The reason was, yes.
Excuse me, could you please share again your screen because we
So just comparing the topographers that we have the option of having. Um, Again, I was saying I used a small head for many years, and the main difficulty was as we did more and more orthokeratology, we found that the smaller heads are really harder to use on children and people with tighter apertures and lids. And it was a challenge for my technicians, even a challenge for me sometimes to get good maps. And so we switched over about 10 years ago to using the Keratograph, and it's far more patient friendly, if you will, when it comes to taking maps. Again, working distance considerations with different topographers as you're considering different options, keeping in smaller heads. You've got to get in very tight sometimes, and sometimes it requires getting your fingers in there or some type of tool in there to help separate the lids and to be able to see and to get the proper image. Sometimes you just can't get in tight enough to get everything perfectly focused, or it's quite a challenge, and you're tipping and tilting heads and pulling lids and everything just to try to get an image. Whereas with the Keratograph, you have a greater working distance, and that allows you to be very comfortable with what you're doing. The patient is much more at ease, and you even have the option again of turning off the bright white light of the rings until just the very moment that the image is captured. So again, it can be extremely patient friendly to do corneal imaging with a Keratograph. Again, that working distance, you don't have to get that close to the eye. With children, that can be important with children and cooperation. We don't have to touch the lids. We don't have to get in that close where the child might pull back and feel intimidated by it. And again, like I said, what you can also do now is using the infrared light source, you can have the instrument itself be quite dim as far as light goes as you're preparing to capture your image. So the patient's very comfortable. They're not blinded, if you will, by these rings of bright light. And then right at the moment of capturing, you just get a flash of light. And so it's again, it's a very patient-friendly experience doing corneal imaging with a Keratograph. As far as obtaining the map goes, from our side of it, what we see on our computer screen is this red circle with these various arrows. And so the arrows just simply give you an idea of where, how to adjust your image. The instrument itself will capture when everything is perfectly focused. And you do have the opportunity to override the manual capture or the automatic capture if you want to. But as you simply adjust the joystick, moving it up and down and left and right and forward and backward, these arrows direct you to capturing an image. And so I hope this works. I'm going to try playing a video and see if this works in translation through this internet connection. But this is just capturing a Keratograph. You just push in until you come into focus. You'll start to see the arrows appear, and the arrows just help you to align, and once everything is lined up, it just automatically captures. So again, it's quite an easy process. For our technicians and our students, it literally just takes doing this 2 or 3 times, and they've mastered the process. Again, different than my experience with other smaller head instruments that would require much more user skill to get good quality images. So again, just to reiterate, the Keratograph, it's very comfortable for patients and it's very easy for users. It's probably the most pleasant test experience that a patient will have to have done in an office. So from that perspective, and we can't overstate the value of being user-friendly to both the office and the patient, the Keratograph really is about as good as it's going to get for an instrument. So when we look at the output that we get from our maps, and once we reach that stage where the instrument captures the picture automatically, immediately you will be brought to this screen. And what this screen shows you is the raw camera image with the ring placement over that you see on you again to just verify your Myers and make sure that the map you obtained was good quality imaging. And then on the right, you have your color scale, your color image of the curvature, and you have the opportunity again to change that map quite easily by using the menu at the top where it says axial or sagittal curvature. You simply click and drag this down to other map options. Also on the left side beneath your picture, you have again your raw data. You have your keratometric readings, you have your corneal diameter, you have your eccentricity of the cornea, You have various other data that is there, including quality of your scans. So everything immediately, the second you capture an image, this is what pops up, and you immediately have the ability to evaluate the quality of the capture and decide whether you need to do it again. Again, one of the map that I use probably more consistently in practice is my tangential curvature map. And this is the same eye, just switching the map from an axial to a tangential view. We also have elevation information that can be obtained from our map. And this is just simply another choice in your drop-down menu. You've got your image still on the left, but now we're just changing our view. So if you prefer to look at corneal elevation information, and sometimes we do, especially as we're looking at irregular corneas and as we're deciding on different types of lenses, whether it be corneal or scleral, sometimes having elevation topography is very helpful in that regard. And then, of course, we also have this refractive map, which tells us corneal refractive information. And I use this quite significantly in orthokeratology treatment. And I'll talk about that in just a moment when we get into using the instrument for Ortho K. This refractive map really comes in handy. Just a couple other points before we move on to how we would use the Keratograph for contact lens information and design. There are some other measuring tools that you have the option of as you look at the picture of your map on the left, and I'm going to go back to that for just a second. So this picture you see on the left of your eye with the Myers and the rings on it, even in this view, as we look at it, you have the ability to draw and measure things on that image. So the map does give us corneal curvature and it gives us corneal diameter data, but sometimes I want to measure different chord lengths on the eye, or I want to look at the corneal diameter in different meridians. And so then I have the ability again to simply drag and drop this line or lines across that will measure for me. So again, this comes into play. We use this on in the university setting. We try to be very scientific about our approach to contact lens fitting, and in particular in the area of soft lens fitting, where it can often become somewhat unscientific by simply using disposables and using the same lenses on everybody. We try to choose a better way to do things, and that is we try to match the lens diameter to the corneal diameter as much as possible. So we're measuring corneal diameter on every patient that we fit in every type of lens because we want to optimize lens diameter to corneal diameter. And so again, these measuring tools give you the ability to get a quick, easy measure of the cornea and then make sure that we choose a lens diameter that's most appropriate for that eye. If you enjoy prescribing multifocal contact lenses, particularly GPs, which I know I do, the measuring tools also can be very handy for giving us the information that the lab is looking for when it comes time to create a multifocal lens. So for example, many translating GPs the lab will want things like the palpebral aperture, the corneal diameter, and the distance from the lower lid to the bottom of the pupil. And you have the ability again to quickly measure those bits of information very accurately off my image on the left, which matches what the lab is looking for in their schematic on the right. Another thing that comes into play, particularly with multifocals, is pupil size and getting a good, accurate evaluation of pupil size in both bright and dim light. The pupillometry option is really great for this. What we have is the instrument itself lays dark and allows the pupil to dilate to its maximum size, and then the instrument will flash a bright light and the pupil will immediately shrink to constricted level, and then over a 10-second period will dilate back up to a dark light pupil size. And so this allows you to get an idea both of pupil size in bright and dim light. And when it comes time again to multifocal contact lens design and deciding the parameters you want in that area, pupillometry options very helpful here too. As mentioned before, you do have the ability to take really good quality anterior segment photos with a keratograph, both with white light, with cobalt blue, with rat and filter built in, as you see here. You can also take infrared pictures. So you have a lot of different types of options for anterior segment imaging that are included as just part of the keratograph. Again, we use this for patients, particularly takes wonderful, again, fluorescein images. So even though I have an anterior segment camera separately, I honestly feel like the fluorescein images I get with my keratograph are better than my standalone anterior segment camera. So often when we're looking for fluorescein patterns on GP or scleral lenses, Ortho K lenses, or even fluorescein staining of the cornea, we will use our keratograph to take those pictures, and they do great quality. You also can take video as well using these same settings. So if you wanted to record a video of a patient wearing a contact lens as they blink and watching the fluorescein patterns, again, you have the ability to do that. Also, again, the dry eye testing, and again, many of our contact lens wearers have some degree of dry eye complaints or symptoms. You have the dry eye testing opportunity with the keratograph to have the non-invasive tear breakup time and meibography and redness and tear meniscus and a whole host of measurements to help you to quantify dry eye and help to decide how to better manage patients with borderline or with symptomatic dry eyes. Again, the infrared light really helps with this dry measuring because it allows you to get an idea of tear production and tear breakup time without stimulating tear production through shining a light in the patient's eye. Like we often do with a slit lamp when we're trying to look at tears, that brightness of our slit beam sometimes can stimulate reflex tearing. And with the infrared light that's used in the keratograph, you can avoid that and get a more accurate representation of the patient's tear stability. So that's just a kind of a walkthrough on some of the features of the keratograph that are particularly handy in contact lens practice. I want to switch gears a little bit now to talking through actual contact lens, using the instrument for contact lens choice or design or development. Again, for the most part, with our basic soft lens wearers, which we do again baseline keratograph on every patient who's got a normal cornea who are about to fit for the first time or refit into a new lens, we'll get keratograph on every patient, and we will essentially use what's in the yellow boxes highlighted here as the cornerstone of helping us decide what lens we're going to put them in. Obviously, the keratometric readings are important, but also the corneal diameter. And so we're even as we move into the world of fitting lenses off sag information or sagittal depth, sagittal height information with scleral lenses, and some hybrids, we try to drive the point of sagittal height and sagittal depth home to our students, even for soft lens fitting, because we want them to understand that concept that really a cornea isn't just about the corneal curvature, it's about the corneal curvature and the corneal diameter and how they combine to create an entire shape of an eye. So we want that corneal diameter data measured as well. And again, for our basic fitting, this often is all the information we need to get started with a fit is what are the Ks and what is the corneal diameter. Now, if you're getting into fitting a GP or a soft lens, for example, you do have the option of working in the lens fitting software, which has got dozens and dozens of lens designs populated into the design software. For the purposes of simply giving you a simulation of what a fluorescein pattern might look like, what a diameter choice might look like. Again, and as you get into patients with more toricity and irregularities, this map can help you. You can see as you make changes to a lens design, whether it be in diameter, base curve, or in the peripheral curve system, you can see the impact on the fluorescein pattern through the simulation, and you can quickly scroll through, again, dozens and dozens of different lens designs that are in the system to help you evaluate what those fluorescein patterns might look like. So if you like the idea of having this fitting software to give you an idea, make sure you're on the right track with what parameters you're interested in fitting, or if you have a lens design you like to fit, you can choose that design. It will immediately fit the eye with the basic parameters that that would be optimized. And then again, if you want to make adjustments, you certainly can make adjustments. But again, it's showing you fluorescein pattern, and it's showing you tear meniscus height. As you see the scale down the left side, it's showing you how much clearances you have. Now, sometimes when we've done a lens fit and then we've taken images of that patient's, that lens on eye, we can come back and take images or video of the lens on eye and put them side by side with our lens design that we use to create that lens. So we come into the lens design software, we choose a lens, we fit that lens, we order it, and we have the patient back. We put it on and we can take pictures or video, and then in a side by side, we can put them up and see how everything compares. In particular, if we want to make adjustments to the fit, we would have that option as well here. But this is showing you actually video, and it's not playing right now, but this is actually a 20-second video on the right of the fluorescein pattern. So it gives you the dynamic look at the tear layer and the fluorescein pattern as opposed to just the snapshot on the left, but both of them are helpful, particularly in a side-by-side comparison. So just want to wrap up Keratograph by talking about how we use it in orthokeratology, because again, I think there's a lot of great aspects to the use of Keratograph for this, and for the longest time, this is, and it still is the main tool that I use for all my Ortho K patients. Well, we do screen our patients with a Pentacam at the initial fitting, looking for any posterior corneal issues. Honestly, enjoy the features of the Keratograph and the information it gives me for Ortho K even more than I do my Pentacam. So for orthokeratology, we've got three essential types of maps that I'll use for the most part. One is the tangential map. And of course, the tangential map will tell me how I'm doing with getting my treatment zone properly positioned for the individual patient. So this may be, is it centering well? Is the size of the treatment zone appropriate for the patient that I'm working with, et cetera? And then we can do a compare to refractive map to tell me exactly how much myopic correction I've achieved with my fit. And this is valuable again, because if I know the patient's prescription prior to Ortho K, I can then tell how much correction I've achieved, and I can predict strictly off of their maps what their acuity should be. And so we'll often run our topography prior to getting the patient back into the exam room. We'll just walk them from the waiting room immediately to the keratograph and then to the exam room. And by the time I've reviewed their topography, I can pretty well go in and know the patient's acuity, refractive error, and their status without even checking it on the patient themselves. The other thing that I like to use is the compare 3 map to see how the treatment has evolved over time. So let's talk about those and look at those. This is actually a patient who we fitted in Ortho K lenses about a year and a half ago. He was actually a 20-some-year-old graduate student whose prescription was progressing significantly as a PhD student at the university, and wanted to consider myopia control even as a 25-year-old. And so we did some baseline measurements with our keratograph. You can see his corneal topography prior to instituting the Ortho K treatment. We fitted him with lenses. We documented the fit of the lenses with topography or with the imaging equipment. And then we began the treatment. So at 1-day follow-up, you can see we've got a little bit of reshaping going. Actually, sorry, this is actually at the day of dispensing. We had him put the lenses on and leave them on for a half hour and took them off. And this was the 30 minutes post lens wear image. And you can see again, not a lot going on, but already some reshaping. We can see that our treatment right now where we are getting flattening is happening within the pupil where we want it. As we move on then to a follow-up visit over time, this would be probably a 1-week visit or 3 to 5 day visit. You can see again the correction starting to form centrally. You can see below when we look at the red and blue line, this flattening occurring in the corneal shape and the steepening in the mid-periphery. We're happy with the positioning of the lens. So again, our tangential map is showing us is the lens treatment properly positioned over the pupil, and is it developing into a large enough area of treatment for our individual patient's needs? Again, probably a smaller for younger children, but a little bit larger for an adult. And again, over time, we continue to see that treatment zone developing, filling out with better correction for distance and a little bit larger area of correction, but again, maintaining a central position over the patient's visual axis. And so this is, again, how we use our tangential map on a visit-by-visit basis to watch the unfolding and the evolution of the treatment zone over time. Now, when that patient comes back at follow-up and we do a compare to refractive map, and this is the map I was talking to you about before, this is our above upper left, this is our pre-treatment map, and this is our map now, looks like 3 days, because this was on October 23rd and this was on October 26th. And so after 3 days, what we can see if we compare, if we look down here at our grid, is that we've achieved about 3 diopters of myopic correction at the base of this area of blue. So again, if my patient coming into treatment was a 3 diopter myope, then without even checking his acuity, I would predict that he would read 20/20 the minute I walk into the room and have him read the vision chart based upon this. At the same time, if his prescription prior to treatment was minus 350, then it would be entirely possible for me to expect that he's still going to complain a little bit of distance blur. Maybe he's going to be 20/30, and I would expect to get a refraction of a roughly minus 50 to get him properly corrected. Where this comes in handy again is it can be challenging with our Ortho K patients to get good refractions sometimes, especially with children, especially when there's a little bit of cylinder involved. And so this refractive comparison map allows me to know the amount of refractive correction I've achieved through my treatment without having to rely on subjective assessment of the patient, giving me feedback on how they're seeing, or trying to measure, do a manifest refraction over an Ortho K corrected eye. So this, again, is something we use on every patient over time to see exactly how much refractive correction we've achieved relative to our starting point before we began the process. And again, the compare 3 map, I love this map as well. I love to do this for my Ortho K patients because we can start off again with this is our baseline, and this is 3 days, and this is, now a week later. And what it really tells us is it shows us in a snapshot here the evolution of the treatment over time, but also on the upper maps, it shows us the difference between the upper left map being from day baseline to day 3, and then the upper right being from day 3 to day 7. And what this often can show us is that while we're not getting more correction for myopia in the central part of the visual axis, we may be getting more correction for myopia peripherally, which is why patients will often feel like even though their vision is good, it subjectively gets better over time because we see the treatment zone expanding a little bit and getting more distance correction. So this will show us the impact of what happened from, let's say our 1 week visit to 1 month, or from our last appointment, which might have been 9 months ago or 6 months ago, to our visit today. What's been going on with the vision just in the last, say, 6 to 9 months? So this compare three allows us to take baseline and then our current, and then put a snapshot of our topography any point in time along that meridian in between to compare. So that's just kind of a walkthrough of the keratograph. Again, as far as corneal topography goes, it's hard to compare to all of the features that a keratograph can give you when it comes to assessing corneal shape, the various maps and ways you can look at the cornea, the measuring tools, the imaging tools, the dry eye modules. I mean, it's more comprehensive than any other corneal topographer that exists. And so again, if your interests lie in a corneal topography, and if in your practice you're doing, the vast majority of your patients are regular corneas, I think that a keratograph is a very powerful tool, and again, will really help your practice. I want to move on now to talking a little bit about the Pentacam, and then we'll wrap up again with some software integration at the end. So the Pentacam, again, in our practice, we use on patients with irregular corneas. We also use it as a detection of disease tool. And so any patient who we have a question about potential corneal disease, or we know there's corneal disease, or they're pre or post surgical, or anything other than a straightforward regular cornea patient, we're going to run our Pentacam on. So again, if your practice setting is such that you're doing more irregular cornea work, you're doing more disease work, then a Pentacam may be a more appropriate instrument in that setting. Again, for diagnosing and monitoring progression of disease, for contact lens fitting, again, just like with the keratograph, you have a lot of powerful tools for contact lens fitting on a Pentacam, and then again for those peri-surgical patients. So the way the Pentacam works, as opposed to the keratograph, which is a reflection-based Placido disc system, the keratograph is a rotating Scheimpflug camera, which takes a cross-section of the cornea and then rotates very quickly and takes a series of cross-sectional images of the cornea, such that with the picture on the right, for example, you can see this would be the number of images that the Pentacam would take on an eye, all going through the center of the cornea. Because these are cross-sectional images, Scheimpflug camera images, it's not tear layer dependent, so that even on a patient with a very coarse epithelium, a severe dry eye, or a keratoconus patient who's got epitheliopathy, you can still obtain good quality maps, even while you might be challenged to get maps on those patients with a Placido disc system. So again, this slit beam, this rotating camera can give these cross-sectional images, and then all of them go through the central cornea. And because of the size of the beam, we're getting really limbus to limbus information and then some. These are the images that you will get on an individual basis. We do use these Scheimpflug images quite a bit to assess our cornea after we've scanned it, looking at scarring or thinning or focal irregularities. You can rotate your Scheimpflug image and look at each of them as an individual cross-section, as well as the map that the instrument creates utilizing all of those cross-sections. So the 3D images are used to construct, or the images are used to construct a 3D model. And you can, again, look at individual scans, but you can also look at them as a series. And the construction gives you front of the cornea data, back of the cornea data, front of the lens data, iris data, and even some anterior or posterior lens data. So it's giving you information about the shape of everything from the anterior cornea to the posterior lens of the eye. And so again, where this comes in handy is really understanding corneal pathology and differentiating potential corneal pathology. This is a wonderful case of a patient who was seen in our primary care clinic, a contact lens wearer with presumed keratoconus is what they were referred for. This patient was having issues with quality of vision. They were referred for evaluation after they had a placido disc topography done, which showed an area of inferior steepening. And of course, we ran a Pentacam on them, and what the Pentacam showed us was that while they do have this anterior corneal irregularity, the posterior corneal surface was actually quite normal. And so we were able to rule out keratoconus as the reason for this patient's irregularity and look for a better reason for why this was occurring, whether it be contact lens warpage or other factors. So the Pentacam, again, giving us corneal thickness, anterior and posterior curvature and elevation data is very helpful. And then again, the battery of tests and outputs and information you can extract from a Pentacam is really staggering. Here's another example of where corneal tomography really comes into play with screening for patients. The topography on the left is a patient which would appear to have standard regular corneal astigmatism, a decent amount of astigmatism, a couple diopters, but quite regular in appearance, certainly doesn't meet any criteria for irregularity. And yet when we look at the posterior surface of this eye, we do see an area of focal thinning. And so this potentially is a patient who has keratoconus or the early onset of keratoconus, even while their anterior shape map is regular. This would be difficult to obtain from corneal topography because we just don't get that posterior surface information. And again, the other Pentacam outputs that are wonderful as far as screening for ectasias, the map on the left that you can see is the Bellin-Ambrosio ectasia map. The upper left of we have 6 images, as you can see. The upper left picture shows, again, what looks like a fairly regular with the dual corneal shape. But the posterior surface shows that hot spot, which you can see right there. And because of that, when the instrument runs its ectasia screening, this patient is definitely flagged as likely to have a corneal ectasia because of the way it analyzes this posterior shape change. So again, screening for irregular corneas and early onset keratoconus. And then also we have this, we call the CSP report now, which is kind of a newer aspect of the Pentacam. And the CSP stands for Corneoscleral Profile. And what this does is it gives us information about the eye beyond the borders of the cornea and out onto the limbus. And this gives us really scleral shape information, which the importance of that, of course, is in fitting contact lenses. Just another example of the powerful nature of the Pentacam and what it can do for us. These are 2 different patients that I've seen in my practice within the last several months. Both of them were presenting for contact lens fitting, presumably in both cases for post-LASIK ectasia. And they certainly both look to have post-LASIK ectasia by their anterior curvature maps. But interestingly enough, when we look at the posterior float data, we can see on this patient that we have a hot spot on the posterior cornea, and this patient does indeed seem to have post-LASIK ectasia. On the contrary, this patient does not have a hot spot on the back of their cornea. And this patient, while they were diagnosed with LASIK ectasia, I had a discussion with them about the fact that they may not have ectasia, but instead may just have had irregular healing or a problem with the treatment and the way their eye responded, but it was not necessarily post-LASIK ectasia, which means that doing a treatment like corneal collagen cross-linking for this patient may not be appropriate, where on our previous map, this patient was referred for corneal collagen cross-linking and did have it done. So this posterior elevation information is very helpful in trying to differentiate between various disease processes. And so again, the Pentacam really powerful in that regard. This is another patient, again, which is a post-graft patient who wears scleral contact lenses and presented with some complaints of foggy vision. Of course, we know with scleral lenses, there's a multitude of reasons why a patient might present with foggy vision. It could be the tear reservoir, it could be the anterior lens surface. In this case, however, we had obtained a Pentacam prior to lens fitting in 2014, and were able to repeat it again in 2016 with the complaints. And his Pentacam using the corneal thickness indicates that he's getting corneal edema, possibly from an old graft wearing a scleral contact lens. So in his case, we needed to modify his contact lens to reduce the corneal edema, which we were able to do. Again, having the Pentacam information helped us to properly diagnose that he was getting corneal edema from his scleral lenses. So let's talk about the CSP report a little bit. There's so much information that we can obtain from this data, but what you can see on the left is your individual cross sections of the anterior eye that give us the profile of the cornea in the center in the gray zone, but then also the sclera with the various color sections of that map. So let's go through this one by one. The CSP color map gives us corneal and scleral elevation data on separate reference spheres. So when we look at the map on the lower right, we see this dashed line, and you need to be aware that, again, the data inside the dashed line is using a different reference sphere. In this case, 8.1 millimeters is the corneal best fit sphere radius, whereas the scleral best fit sphere radius is 11.4. So these are on separate scales, and so you don't want to interpret the information as a whole. You want to interpret corneal data as corneal data and scleral data as scleral data, but it's extremely helpful to do that. This is an elevation map, so the reds are higher. So this is the high points of the sclera, and these are the low points in purple. So again, this map showing us someone with essentially a with the rule scleral shape. So what else can we get from this information? If we look at the upper right section up here, it's giving us important information. It's telling us about the shape of the sclera. It's showing us, in this case, that our sagittal height in this ring at 15.5 millimeters is around 4,095 microns. It also tells us that we've got astigmatism in this zone of about 268 microns. So clearly this patient would need a toric lens haptic to better fit the eye. We'd want this scleral zone of their lens to be toric and approximating 268 microns, given the options that we have. On the upper left picture, we see the slope of the sclera. In this case, 40 to 41 degrees is a pretty average slope. So other than this sclera being quite toric, it's actually fairly typically shaped for a sclera. And so a standard toric haptic should work well for a patient with this eye shape. Moving on, we can see in the box on the yellow box now, the white to white of the cornea, so 12 millimeter lens or 12 millimeter corneal diameter. And this again is helpful in choosing the proper diameter of scleral lens you'd like to fit. And then again on the box in yellow now, we can see that when we set our corneal clearance or the amount of vault we want in our lens fit, this gives us then the predicted sagittal height of the scleral lens at the diameter that we have chosen. And so in this case, at 15.5 millimeters, we would like to have a lens with 4,395 microns of sag. So this one map can really point you to the ideal scleral lens in your fitting set before you even begin the process, so that when you reach for your diagnostic lens, you've chosen the proper diameter, sag, and whether you need a toric or spherical haptic, so that that first lens you put on, in theory, can be the best lens, and it's one and done when it comes to diagnostic fitting of a scleral lens. So again, in this case, we see the data. We've already kind of talked through this one. I do want to show you that we have developed, or the Pentacam has developed, some fitting guides that go along with different types of scleral lenses that will walk you through the process that we just worked through, so that if you don't want to use software itself to design your lens, but you particularly have a lens you like to work with, you have a CSP report that will show you how to use the data from your output to obtain the best diagnostic lens. In this case, this is a fitting guide that's designed for Zen Lens that walks you through how to choose the proper lens diameter, the proper sagittal height of the lens, and then to select the peripheral curves, both in terms of how steep or flat, as well as how much toricity you need to obtain the optimal first fit. So again, just to summarize before we finish with software integration, the Pentacam is an extremely powerful tool. We've really just scratched the surface on the applications it has for anterior segment disease, but indeed in terms of contact lens fitting, especially as we're looking at using more and more scleral lenses, the Pentacam has increasingly more alternatives and options for doing scleral lens fitting that are that can be extracted from the data, as well as software that is integrating with the data to actually do the lens design for you. And so just again, I want to switch over to a brief discussion of software integration with both of these instruments. It's important to note that in this time of pandemic in our world, that we're looking at doing things differently. I think there already was a push for increasingly more empirical lens fitting, even with specialty lenses. And I think that the elimination of diagnostic lenses or reduction of utilization of diagnostic lenses in office is going to increasingly be a priority. And so as we have software that we can do lens design, where we can often get the first lens that we can order is the perfect lens, or it's very close to the ideal lens, so that we no longer do diagnostic lens fittings, but we do high quality ocular surface imaging, and then use software to create the best lens and order that lens, so that we've now gotten almost an ideal lens with our very first lens we put on. This is the way of the future. And so there's a couple different software programs that you can use with either the Keratograph or with the Pentacam. Wave is one of those software programs. Wave is a very robust software integration where you obtain your map with your instrument, and then you simply click on an external link. It opens the Wave software design software, and it pulls in the patient's topographical information. Once that information is there, you can choose the type of lens you want, be it an Ortho K lens, be it a scleral lens, a standard corneal lens, a multifocal GP, whatever type of lens you want to create, the Wave can create that lens for you. And again, within this very powerful software, you can create the ideal lens for that patient. Both you can have the option of spherical, toric, and even free-form lens designs with everything extremely customizable. So again, using the Wave software for orthokeratology is very successful because we're able to create not only the right amount of reverse geometry to that lens, we're able to set the tear layer height that we want, but also we can build in very subtle amounts of toricity into our landing zone, into our alignment zone, and really get very nicely centering lenses, much better than we get with many of our diagnostic lenses that are not customized. Again, Wave also is able to be used to design scleral lenses, where we can set things like the amount of vault we want centrally, our lens thickness, designing our haptics in a free-form manner to completely customize to the shape of even a fairly irregular scleral shape. So again, a very powerful tool for very highly customized lens design. Eyespace is another software that it does integrate with the Keratograph. It also allows you to create, again, Ortho K, corneal lenses, torics, multifocals, etc. Very customized lens designs. It also has an application for designing sclerals empirically right off of your map. And then there's also more lenses coming, both Ortho K and Scleral Designs. I've been using the BE-free Ortho K system with my Keratograph for several months now and hitting at extremely high rate of accuracy. Literally have about 100% first lens success using these software integrations for Ortho K, getting optimal fits from just a single lens order. And again, the scleral work that we can do between Wave and ScanFit Pro is another software that integrates with Pentacam and allows you to create these very elaborately shaped lenses optimized for even very irregular eye shapes because of the free-form nature and the extremely good data that the instrument can provide. So having a Pentacam allows you, again, to be creating very highly customized free-form scleral lenses even now. You could start today if you had that instrument in your practice. So again, just to summarize between these two instruments, when it comes to, again, the capability of the different things that you can do with both of the instruments, again, be it the keratograph and the imaging and the dry eye, etc., whether it's the Pentacam and the exquisite posterior corneal curvature information it gives you in the way that you can detect ocular disease so effectively and accurately. You're really managing anterior segment disease at the highest level with either of these instruments. The applications for specialty lens fitting are just scratching the surface. I mean, they're already there, but I feel like there's going to be a race by many lens manufacturers to try to bring more and more lens design software to these instruments, because I think everybody recognizes this is the way of the future, and everybody recognizes that these two instruments are core instruments in this area, and that they're going to have the attention of manufacturers of lens designs wanting their lens design software on these instruments in particular. So I think that having either of these instruments is going to give you accessibility to the latest and greatest lens design software that's available on the market, whether it's Ortho Ks, Sclerals, GPs, monitoring for ocular disease, managing your patients long-term with disease issues, or software integration. There's really not a more comprehensive pair of instruments when it comes to managing the contact lens wearer in the anterior segment disease patient in your practice. So for the advanced contact lens practice that wants to be able to provide the highest level of care, both in terms of managing the health of their patient and the highest quality lenses, I don't think you can go wrong with either of these instruments. So that wraps up my discussion, and I have time to take questions as long as you'd like to stay.
Okay, so thank you, Dr. Jedlicka. That was a beautiful presentation. I got lots of compliments in the chat already that you did it so good. You explained it super easy, the difficult things as well. And I think you gave us, everybody of us, a super good overview about contact lenses. And of course, which device should you prefer for which purpose or for which application? Thank you very much. So I have a couple of questions from Q&A. So there's one quite interesting and a little bit difficult question in my eyes. So normally for the elevation maps, you use a spherical reference sphere. But the question is, when do you use toric ellipsoid as a reference shape, and what is the cutoff value?
Well, to be perfectly honest, I don't use a toric reference sphere ever. If the question becomes when to use a toric in your lens design, again, I think it depends on the lens. If we're looking at, for example, Ortho K lenses, I think most people are advocating that if you have toricity of more than about 35 or 40 microns, you want to implement toricity into your lens. I think when we get out onto the sclera, that toricity is greater. It's probably more like 125, 100 to 150 microns of toricity for sure. As far as looking at the shape using a toric reference, I guess I don't do that because the spherical reference gives me the information I need from a toric perspective.
Okay, good. Thank you very much. There is another question. I just read it to you. So what about fitting soft contact lenses with sagittal height? You only talk about scleral lenses. Do you use the elevation map for soft lenses? So the CSP color map. And can you explain what is the sagittal height for a soft contact?
Sure. So let's talk a little bit about soft lenses. So if we're just talking about, let's say, disposable soft lenses, now we're talking about your daily or biweekly or monthly lenses. I've got graphs, if anybody wants them, that can tell you the sagittal depth of every disposable lens on the market. And what you'll find again is that sagittal depth ranges from 3100 to 4100, depending upon the lens. And so indeed, there's a lot of forgiveness with soft lenses, we know, and yet we don't want to neglect the idea of trying to put a proper sagittal height lens on an eye. So my philosophy is I don't get into the depth of running a CSP on every conventional soft lens wearer. And I will just say it's probably a matter of time constraint. I would say this much: if I had a patient, I would certainly run a keratograph on every patient, and then going back and looking at your keratograph, you can see what the corneal diameter is, and you can see what the corneal shape is. And you know that if my corneal diameter is roughly in the middle, and my corneal shape is roughly in the middle, that I should be able to use most lenses. Should work for that eye. Obviously, if a lens comes in multiple parameters, I'm going to choose the more appropriate one. When you get some outliers, so this is a great point, and I actually love this question because I would probably screen with my keratograph, but if I picked up a patient with a 12.8 millimeter cornea on my keratograph and a 45 diopter corneal shape, and they have a history of not having good success with soft contact lenses, absolutely, that's a perfect person to run a CSP, actually measure their sagittal height, and then consider, do I have a lens at my disposal that has the sagittal height I need, or do I need to go custom? And then when you start going into custom soft lenses, now you need to talk to the manufacturer of those lenses, and they can give you sagittal height data for their products. And then you absolutely can marry the proper sagittal height of the soft lens to the eye. And of course, that system works differently because soft lenses, we want to actually overvault a little bit. But again, working with the manufacturer, you can certainly obtain that data. So is there value in doing it on soft lens patients? I'd say the number of patients that I would go to that extent where I would actually measure their sagittal height at a given ring diameter of a soft lens that I want to fit is pretty small, because you just don't need that on more than maybe 10% of your patients at most. But I think the capability of doing it and to be able to provide that level of precision is amazing. Again, I think you can get by using your own intuition and the data that you get from a basic map on 90+% patients.
Okay, good. Thank you. I think this answered the question. There was some other question made from the same guy afterwards, but I think you answered it with the second part of your answer. Yeah, let's go to another question. So this is from my side. You do myopia management as well, is it correct?
Yes. Mm-hmm.
Okay. When you fit Ortho K lenses, What do you do different when you fit it for myopia management?
Well, a few years ago, we didn't do much different because
Yeah.
we didn't have a lot of options. And one of the things that I think is great is we recognize now that for children in particular, and younger children, the ones that are particularly at risk for that high level of myopia change in a short period of time, that's 5-year-old to, let's say, 14-year-old window, those children, we really like to have a smaller treatment zone. And because keeping that area of under correction, if you will, the red ring on our Ortho K map closer to the visual axis seems to help slow down the progression more. And I think you see that when you look at the studies that have studied Ortho K for myopia management. Earlier studies done from 2003, 2006, 2008, in that time frame, you saw what, a 40 to 50% reduction in progression. But you have to recognize that these lenses that were used in these studies had larger optic zones, larger treatment zones. In the last couple of years, as we've gotten more aware of the need for keeping the treatment zone in tighter, and as we've got more lens options that can do that, we're seeing a higher control rate from Ortho K, now more like 50 to 60% reduction in progression. And I think that's all due to how we approach the treatment zone and the optic zone in our Ortho K lens. And so what I'm doing now is I'm using software that's integrated with my instrument to customize that optic zone for my individual patients. So rather than default everybody getting a 6mm optic zone, we are now using 5.5 or even 5mm optic zones regularly on our Ortho K patients. And of course, for an adult, that may not fly. That may not work because a 5mm treatment zone or optic zone on an adult may create too much night vision issues, and they don't need the myopia control as much. That 7-year-old is not driving a car. They hopefully aren't out a lot at night. They should be in bed. So, for them to have a 5mm optic zone on their Ortho K lens and get a smaller treatment, that doesn't bother a 7-year-old at all, but it does help control their myopia. So definitely taking a different approach now with children versus adults, and in particular those children in the vulnerable critical stage of about age 5 to 14. We definitely are using our software that integrates with our instrument to create customized lenses that center better and provide a smaller, more defined area of treatment for vision correction that also then will be more effective at reducing progression.
Okay, thank you very much. One last question we do at that point, and this is in our clinics, there are clients, they are only using 3, 6, and 12 months contact lenses.
Mm-hmm.
Do you have any advice from your side?
Well, again, if the question is, can I still use these instruments to help fit those patients better? Of course, I am assuming that if patients are using 3 and 6 and 12-month replacement, that they have at least as many parameters or more than the daily disposable patient. So my guess is that you actually have more base curve and diameter options for those patients, or at least as many as I would if I'm doing it every day or 2 weeks or every month. So in your case, choosing the best or optimal base curve and diameter for your patient is even more important because you have more to choose from, and it's more likely you will get the wrong one if you're not doing that. So again, if I have a patient where their K readings are a little bit on the flat side, and I only have one base curve option, I'm okay with that base curve. But if I have 2 base curve options, I certainly don't want to pick the steeper option if my patient's K's are flatter or their cornea is smaller. So I think in terms, again, prescribing lenses, more frequent or less frequent replacement certainly doesn't change that at all. If anything, it makes your proper diagnosis of the anterior cornea or anterior ocular surface, the ocular surface shape, even more important. And I think that's the important part.
Okay, good. So one final question is about the technology or about the interface. I will answer that from my side. So the question was, can you connect the Pentacam or Keratograph with the Myopia Master? You did a great, you had a great idea, because both devices, they would work perfectly together. Either the Pentacam with the Myopia Master or the Keratograph with the Myopia Master. You can use the same data management, patient data management, but so to connect it, what do you mean with? I mean, you have different kind of measurements you have to do. So you measure axial length with the Myopia Master and topography with the other device. Of course, you can see everything in the same patient data management and open the different software to evaluate the cornea or also the myopic child. So this is from my side. I think we answered all the questions which popped up here. I would like to thank you very much, Jason, that you did this beautiful presentation. I think it was really great done. I said it before that we got lots of compliments already, and I'm super happy that you had time, even it was so early in the morning for you. So thanks again, even if you had to stand up so early. And yes, I hope we can motivate you more often to speak in front of this public. Everybody agrees here, I can see. And yes, thank you again. And I wish you all a good evening, good afternoon, or good morning, wherever you stay in the world. We will stay here for a couple of minutes. If you have more questions, you can just send us the questions here, but we go in another surface so you can't see us anymore, but we will be there and answer your questions in the next 10 minutes. Thanks from my side, or from the side of Oculus. There's also Kai Moses who supported me, luckily, because my computer really striked today. Also Jason's computer did
Mine too.
trouble. Yeah, so we had all trouble today, and then WebEx did the same. So we had some.
It was a stressful technology morning, yes.
It was
day.
actually, yes. Okay, so we go in the other session now, and yeah, keep healthy in these times. Bye-bye.